And many of them obviously came back with the disease, and that very quickly overburdened our health system to the degree that the usual first line of defense, testing and contact tracing, could not longer really be upheld. In some parts of the country, yes, but not everywhere, and especially not in Stockholm, who got the first hit very much. I mean, the spread during the first year was extremely heterogeneous in Sweden, and the big cities, including Stockholm, got worst hit. So we very quickly had to go from trying to contain the pandemic to mitigate its effect. And the mitigation really took, I would say, two major parts. One of them was to try to find where is the biggest risk of getting infected and try to regulate those places as much as possible to minimize the social contacts in those without causing undue harm, because that's very much also in this Swedish system that we are not really allowed to take measures that causes undue harm, and we need to think about it the whole time. So we really took a broad public health view on this, which meant that, yes, we closed big events fairly early on. We did regulate restaurants, who was another hotspot that we saw coming up in Europe, but we did not force them to close, but rather to reorganize their business, to minimize social interactions in the restaurants as much as possible. And that proved to work reasonably well. We didn't see any outbreaks in restaurants in Sweden. And the third area was the workplace. And we did ask all employers and all employees to work from home as much as possible. And once again, context. In the Swedish context, a lot of people can work from home. And actually, we could follow the mobile phone operators and see that about 50% of the Swedish workforce did work from home. And that made a huge impact, because we had some data from Sweden saying that at least 30 to 40% of all transmissions took place in the workplace. So it was very important to close it down, to close them down as much as possible. So I would say that was the sort of main areas, really. We really tried to find continuously places where there was a high level of transmission and regulate them in different ways. And on top of that, we issued recommendations to the population. And then once again, context. In Swedish, the population has a very high level of trust in the government and in the public health authorities in general. We are really outstanding in that way. With anybody, 75-80% of the population will say that they trust in authorities. So we also ask everybody to diminish their social interaction as much as possible. And that seemed to have an extensive effect, because people really did stop interacting very much. They stopped moving around very much and worked from home very much. And last but not least, they stayed at home as soon as they had any kind of symptoms. And we had a change in our sick insurance regulations, which usually says that the first day you don't get any compensation. And that was changed. You got compensation from the first day, and that made it possible for many people to stay home. And we also saw an increase in sick leaves. So people did stay at home when they were ill in different ways. So there, I think that was really the main measures that we put in place. Just quickly, a couple of areas where it did not really work that well. We had huge problems with elderly homes. Actually, 70% of our mortality during the first wave took place in our elderly homes, which are run by the communities and are really places for the extremely frail in our population, with a high level of comorbidities and also very old, and the expected lifespan after you enter a place like that is usually about 6 months or so. So it's really frail. But still, a lot of these places got infected, and the spread in those places were extensive. And in spite of trying to do something about it, it proved to be very difficult because they didn't really have the capacity to change quickly enough. So it's a big learning experience for Sweden that our elderly homes really need a lot of improvement. The other area was that we did not really reach the part of our population with background in other countries. And we could see that if you had a background from Africa or the Middle East, your risk of ending up in a hospital, dying, or ending up in an ICU was 5 to 6 times higher than for a population that's been living in Sweden for a long time. And there was a number of different, not least socioeconomic reasons behind that, but also integration problem behind that. The third area, which I think is important to measure, is that we early on decided to keep the basic schools up to the age of 15 open. And after an extensive discussion with the schools and the teachers and the government, we issued a number of recommendations how you could keep on running the schools in spite of the pandemic. And once again, it worked reasonably well. We did not really see an extensive level of disease, neither among teachers nor among the children. There has been a lot of discussion around what kind of evidence did we use. I would say that in hindsight, in Sweden, we did use we looked a lot of the data that we continuously collected in different ways, and that was steering our measures very much, and maybe not classical academic evidence in that way, but we did do a lot of continuous modeling and evaluation of the data that we got, and that to a great extent steered the kind of interventions we did. Interesting to hear what my colleagues think about especially the extensive testing that we did during the pandemic. We recently had a review together with our Nordic neighbors that we looked into testing, and it seems like many of us do believe that maybe we should next time try to be a bit more precise in our testing, because the testing costed us a lot of money, and we are still kind of questioning if it really had a kind of impact that we wanted it to have. But I'll stop there for now, and I'm happy to take questions about other.
Thank you very, very much, Dr. Tegnell, and we will be coming back to you later in the question and answer session, and so much there for us to share in the later part of the session. We will be looking at testing and tracing in an Irish context shortly. But first of all, closer to home and to our neighbour Scotland's pandemic response. And we're delighted to hear next from Professor Mark Woolhouse, who's a Professor of Infectious Disease Epidemiology at the University of Edinburgh. You're very, very welcome.
Thank you very much. It's a pleasure to be here. I'm going to talk about a few of the lessons that I think we've learned from Scotland about the pandemic, ones that I hope will resonate here in Ireland as well. And those are the importance of early action, the impacts beyond public health, the role of the public in the pandemic response, and briefly the role of the scientific advisors to that. So let's start with early action. The guiding principle for responding to an outbreak or an epidemic of an infectious disease is that early action can be less drastic action. The rationale for this is very easy to understand. You do not have to impose severe measures, whatever kind they may be, to drive down the number of cases if you haven't let them rise up in the first place. Early action is key. Many countries around the world failed that test in early 2020. Scotland was one of them, but one of many. But not all countries did. And though the Scottish government were warned as early as mid-January 2020 of what they were facing, those warnings were not backed up by our own public health agency. Since been renamed since then, but it it's now called Public Health Scotland. And even more surprisingly, they weren't backed up at a UK level by SAGE, the senior scientific advisory group to the UK government. They weren't backing up the warnings that some people, including myself, were making in early January. And the result, as the UK COVID inquiry has put it, was lost February, where just not enough was done to prepare. And I don't know if that resonates here in Ireland, but it's something we feel very strongly about in Scotland. The way to address lost February is to ensure that ministers have direct access to the right expertise. That's one. And the second is we have the best possible situational awareness. There were a couple of reasons why Scotland and the UK didn't respond quickly. Partly it was complacency. We might come back to that about how you actually evaluate your pandemic preparedness, because that's very important. But the other issue was astonishingly poor surveillance. We didn't know the state of the epidemic in the UK in February. If we'd known then what we know now, we would undoubtedly have acted very differently. So this early gathering of intelligence and situational awareness is crucial. Have we fixed those problems? No, we haven't, I'm afraid. So we know the lessons, but we haven't acted on them yet in Scotland, I don't think. The next lesson is about the whole of society impact of a pandemic, something everyone in this room and online is now painfully aware of from what we went through in 2020, 2021. And the Scottish Government did recognise this. In their documentation about the pandemic response as early as April, they were talking about the four harms framework. The rhetoric was great, but in practice, the response was absolutely dominated by public health. There was scant regard for wider societal harms. They were essentially treated as secondary concern. And the result of that was overly harsh and prolonged lockdowns, the unnecessary closing of schools. I do underline unnecessary. We didn't need to do that, but we did it. Exacerbated damage to livelihoods, the economy, mental health, and access to healthcare, which we all have seen unfold. Now, there is a policy solution to the wider societal impact. So the pillars of the policy in Scotland and elsewhere, quite correctly, about saving lives and protecting the NHS. I had a third one: make avoiding lockdown a policy objective. Now, that's not going to happen by decree. So the pandemic preparedness planning needs to set out exactly how we would deliver that objective. The early action I spoke of before, that's one vital component, but another is the role of the public, and I'll come back to that. Do we have that avoiding lockdown policy in Scotland? No, we don't. Instead, what's happened is responsibility for pandemic planning has reverted back to the public health agencies, which simply don't have there, in Scotland anyway, the culture, expertise, resources or leadership required to navigate the whole of society nature of a pandemic. They're just simply not set up to do that. They don't have the capacity. But they're now the ones responsible again. So there's a risk that we end up in the same place. The third lesson is the pivotal role that the public play in a pandemic response. They do play that role, but as one of my behavioural science colleagues in Scotland puts it, the public were treated as if they were the problem, and restrictions were imposed on them and not developed with them. A symptom of this was they were given misleading information that was designed to ensure their compliance with very severe restrictions. For example, the virus does not discriminate. We are all at risk, which was wholly inaccurate, and we knew it was inaccurate at the time, and it drew attention away from those who were genuinely at high risk, the elderly, the frail, the infirm, something established very early on, with the consequence that we were so focused on protecting everybody, we didn't focus on enough on protecting the people who really need protecting. And that led to an awful lot of avoidable deaths. The solution then is to trust the public and to empower them to manage the risks to themselves and those around them, things they were demonstrably willing to do. As I just said, providing accurate information and not misleading information about the risk is tremendously important, but we can also give them tools. And the most effective tool we gave them was self-testing. Now, that was a game changer. The lateral flow tests that we could use for self-testing were a game changer. They could do something that test and trace could never achieve. In Scotland, that allowed us to get through the Omicron wave without further lockdowns. That spared us a lockdown. Would have spared us more if we'd rolled out the technology at the beginning. This is a simple technology. We developed it within a year, and then we sat on it for a year. We didn't roll out for 2 years for such a simple test, but it was a game changer when we did. I think we've learned the lesson about communication, so we now have a chief social policy advisor to Scottish Government to help with that. But we still don't currently have a plan to roll out self-testing quickly and on a national scale. Finally, and briefly, the role of scientific advisors. Now, in some respects, I think Scotland got through 2020 better than England did. We did reopen the schools at a time when this was resisted in England, and we avoided a national lockdown in November 2020, thereby demonstrating that that measure was unnecessary when they did take it in England. So why did we do that? Well, a large part of the reason is by then we had our own independent SAGE for Scotland, as it was called, and it acted very differently from SAGE in England. And one way it was different, it didn't advocate for specific policy interventions. We tried, I was on it, we tried to give the government options. And it took different options in England, what turned out to be better options. We got better policy because the scientific advice was delivered in a different way. And I thought that lesson had been learned when the Scottish Government set up their Standing Committee on Pandemic Preparedness, but even that, memories fade, that committee seems to be in abeyance. It hasn't met for well over a year now. So where Scotland's going to get its scientific advice when the next pandemic arrives is still worryingly unclear. The bottom line is, are we safer in Scotland than we were before COVID? Which is actually quite a low bar, sadly, despite what the preparedness indices told us. But sadly, I can't say with any confidence that we've cleared it, and that worries me greatly. And I think the underlying theme of what I've said is we really should trust and act on the evidence we have and not on people's preconceptions, prejudices, whatever it may be, but actually the evidence, including from other countries, not just from ourselves. And I hope that would indeed lead to a better response. Thank you.
Thank you very, very much, Professor Woolhouse, for your contributions, and we'll speak to you later in the Q&A session. We are now going to move from the international to the national perspective, and our first expert in this section needs no introduction. Dr. Mike Ryan is the former Deputy Director General of the World Health Organization, who is Executive Director of the WHO's Health Emergencies Programme from 2019 to 2025, was one of the most recognised public health experts globally during the COVID-19 pandemic. Whilst working on solutions across the world with over 190 countries, he also managed to keep a very close eye on matters at home. So he is the perfect bridge, so to speak, to take us from that international to the national approach. Dr. Ryan, you're very, very welcome home, and just some really salient remarks already, including, when information is uncertain, it's a challenge for evidence-based medicine.
Great. Thank you. It's great to be here, and it's very interesting listening to Anders and David and Mark, and those stories are repeated all over the world. It's interesting coming from my perspective, because you mentioned, Anders, the issue of context. And you mentioned it too, Mark. The context is different depending on where you are, even within the United Kingdom, between Scotland and England. And that context changes based on geography, where the virus is, what variant of the virus is circulating at a particular time. What is the cultural, environmental, and social context of that society? For example, it's very easy to have people work from home when you're working from home in an industrialized country. You can't work from home when you're on $1 a day and you've got to go to the market and sell your wares. It's completely untenable. So the idea of one size fits all between countries or even within countries becomes very, very difficult. As David said, there are many armchair generals. There are very few. There's an awful lot of people in the something must be done club. And that is the context of public health and health systems currently. If I think about the things that resonate to me, that resonate at the international and at all national levels, I think blind spots, everyone had an issue with that, whether the blind spot was long-term care facilities, the blind spot was migrant communities, or the blind spot was schools getting the same levels of lockdown as the rest of society. But there were blind spots. And that's not that anyone was trying to make that a blind spot or there was some conspiracy to damage. In a rapidly developing situation with multiple pressures, with limited information, people make decisions. And sometimes we need to be able to step back and take that team B approach where you have other people who are able to come into the argument and you're not just reconfirming your own prejudices. You need to have a very diverse group working at a national or international level on policy. And as you said, Mark, it needs to have a broader societal context to that policy. That issue of empowerment and people managing their own risk is something we had tried to do, the idea of getting across to people that no one externally we can inform people of their risks in general, but people manage their own risk. They decide how many times a day they go to the shop. They decide if they get on public transport. They decide if they go to work. All of those are decisions that would increase or decrease your risk of exposure. And we didn't trust communities enough at times to make those decisions. And I can understand why, because health systems were coming under huge pressure. And it's that delay in the initial reaction meant that people were playing catch up. I said, we don't have time to do all this trust stuff. We need to just lock this down now. And that's the kind of thing you do in your own house, in your own family, with your own kids, with, when there's no time, we're late, everyone in the car, it's kind of, there's no democracy in that. So the further you are behind the curve, the more you need to take that approach. It's not the wrong approach, it's just a late approach. And I think I just remember in January and February in particular, in the pandemic, screaming out from Geneva about this is really serious and people need to get to terms with this. This is, and just seemingly for the most part, a kind of a dead response. People are saying, you're overreacting. Whereas if you went to the countries like Korea, they jumped on this, right? But interestingly enough, as David had said, they had a bad MERS outbreak in Korea with huge nosocomial transmission. After that MERS outbreak, and they only had a few hospitals infected, they didn't have that many cases, they invested nearly $250 million in public health surveillance and preparedness, which is a huge amount of funds. Anyone who works in public health will know that's a lot of money. So they had, and Thailand and other countries that have been through SARS-1 20 years previously had much better community health structures, had much better community surveillance, much better participatory surveillance in those countries. It may not have been as sophisticated as many in the West, but their system was much more distributed because they had learned in SARS-1 that they needed that approach. And that was still resonating there. The second thing I think from my perspective is we need to learn the lessons of the past, but as you said, Mark, they need to be implemented. I can tell you the more lessons there are more reports on my desk in Geneva of different epidemics with lots of recommendations. Oh God, they're the awfulest things in the world, recommendations, right? How many recommendations in any national or international system have ever truly been implemented? And that means funded and implemented and monitored and evaluated further implementation. That for me is lessons implemented. And that's really important that it happens. But it's also very important that we don't play the next pandemic like the last one, in the sense of saying the next one is going to be like the last one. So therefore, all we have to do is learn all the lessons of the last pandemic and we'll be fine the next time. The next pandemic may be a different virus. It may have higher mortality. There may be different risk groups. We saw with HIV, it was a pandemic. There was a very different risk group. We saw with Mpox, the transmission of the virus may go along more social or behavioral lines rather than geographic or temporal lines. So we need to be sure-footed to learn those lessons of the past. There were lessons to be learned from SARS-1, as many countries learned, and they did better in SARS-2. But it's not the absolute. There has to be flexibility in that approach. And that's where the data, the science, the evidence becomes very important, feeding that into the system in real time. But then coming to terms with the fact, and you said it, Mark, rapid action doesn't mean perfect action. Rapid action means rapid action. And the more rapid your action, the more likely it is you will have to change your advice later because you're not waiting for perfect information to make the decision. And that's very hard to communicate in modern society. When you come on 2 days after your first advice and say, now we're changing our advice today based on the report that came out yesterday, people get very confused. You told us yesterday it was safe and today it's not safe and our kids can go to school tomorrow, but they can't go to school the day after. So for us in public health or in science, we're good with that. We see new evidence and we change. Societies take a time to catch up, especially when it affects their lives. And they're not going to have time to sit down and examine the evidence like we do. So we need to be very cognizant of the fact that the public's trust is based, and you said it, Anders, where there were high levels of trust, the public were willing to implement without question. But we've seen trust like that erode, and people ask more questions. And they have a right to ask more questions. And we have to respond to those questions, not with irritation. Oh, please stop bothering us, just get out and do this, because that even deepens the trust gap even more. And I think what we managed to do was turn a trust pothole into a trust chasm during the pandemic. It was there before. COVID didn't cause the lack of trust in the system, but we really, hit the ball out of the park when it comes to that. And that's something public health authorities nationally and internationally need to examine. How do we communicate with the public, and how do we communicate uncertainty? How do we communicate uncertainty to people and still take concrete action? And it's really hard. How can you tell someone, I'm not sure of exactly where we are, but I think we should do this that's going to affect your life. And you're saying, hang on a second, you're not 100% sure, and you're asking me not to go to work? So that's a real dynamic tension that people have to deal with. The other thing for me, so that's on trust. The other issue for me in terms of the international to the national is the inequity. And that's not just the inequity of, yes, we have the international story of viruses or diagnostics and not been equitably distributed. I mean, there were literal knife fights on the pans of airports around the world as basic masks and basic non-pharmaceutical interventions, IV fluids and everything else. It wasn't just vaccines. That became the big flag-waving exercise of what equity is about. There was inequity built into the system on everything. And that also happened within countries. And that was the most difficult thing to understand, in a way. The international inequity is, again, baked into the system, and we would try to avoid that in future. But a huge amount of the inequity was between the haves and the have-nots in the system and who could access the system. And we didn't have a good way to target the most at risk. That idea that everyone was at the same risk. It's not true. Everyone was at a very similar risk of being infected, but not everyone was at the same risk of having a negative outcome. And that's the difference between maybe a public health approach and a clinical approach. I may be infected, but I may not die. And in that sense, moving to protect those most at risk and putting resources into those care pathways for those most at risk was something maybe that we didn't do enough of in many countries, and people had to adjust, and they did adjust. So for me, trust, inequity, context, and hearing the national examples, it resonates. But the danger in that is people are trying to find someone to blame at a particular moment. If you ask me, what were you doing on this day? Why did you make that decision on that particular moment, on that particular day? It is very hard to go back and run that movie back in your head. And if everyone does that, and if they're doing that to say, where did we miss an opportunity? That's a positive thing. But if you're doing that to identify a political fall person, or you're doing that to identify a scientific error, or someone to blame for that, then I've seen different evaluations around the world. They're fine in that sense, but they don't go very well because they don't result in anything changing. They may result in someone being blamed and some people feeling righteous, but unless that actually turns into something actually changing. And I don't see that. You were saying the committee hasn't met for a year. If you go around the world, there's a tremendous amount of fatigue. I'm listening to the accounts of seeing Anders online. Probably Anders, I don't know how many times we were online during the pandemic. I'm having a slight case of PTSD right now, and I'm sure we all are to some extent. But unless we go through this process, we're not going to learn. But at the same time, the public want to move on. They had a tough time. Healthcare workers had a brutal time. And I try to, every time I speak to them, because they're the real heroes of this pandemic, in my view. And they work selflessly, tirelessly, at their own risk and risk to their own families, and did tremendous work. And we saw the best of humanity. We saw communities coming together, taxi men bringing people home from late nights at work, delivering sandwiches, local coffee shops, delivering coffees to people. There was a great outpouring of community. But did we exploit and sort of, in some sense, harvest all of that. We didn't. And I think we can do much better in community-based approaches where we trust the community, empower the community, bring them along in the system. Sometimes, and you can't just do that at the start of the pandemic. This is something you have to do between. And my fear is, as we do pandemic preparedness for the future, we're all technological. They're over in Geneva now talking about how they're going to divide up vaccines or how they're going to do this. And that's great. But unless we start to invest in community and participatory public health and have communities ready for the next pandemic, we're going to fail. Not because of the technological and the innovation solutions, but we have not prepared, supported, and involved our communities in preparing for the next pandemic. Thank you.
Dr. Ryan, thank you very, very much. And we'll come back to you later in our Q&A. Our next expert is Professor Ivan Perry, who is from the Department of Epidemiology and Public Health at University College Cork. And Professor Perry, you're going to set the scene for us with observation on Ireland's overall response. You're very, very welcome.
Thank you. I am very happy to be here to participate in this national COVID evaluation roundtable event. My brief is to set the scene at the national level to consider briefly how well Ireland was prepared from a population health perspective in 2019 and early 2020 to respond to a public health emergency on the scale of the global COVID-19 pandemic. I approached this task as a public health physician with a background in chronic non-communicable disease epidemiology and public health nutrition. In the context of the national COVID evaluation, we need to consider the institutional, structural, and operational strengths and deficits that framed our capacity to respond to the pandemic, together with a broader set of contextual factors linked to the fundamental determinants of health and well-being that will help place our overall performance in context, judged against appropriate comparator countries. Thus, I will focus initially on those high-level determinants of health that framed our preparedness, susceptibility, and response to the pandemic before turning to the health system, where I will focus on public health capacity and infrastructure. In 2019 and early 2020, Ireland could be described as a politically stable, high growth and socially progressive country with strong EU alignment and record employment levels. The two dominant governing parties, Fine Gael and Fianna Fáil, hover towards the centre of the political spectrum, both pro-market but socially progressive and committed to relatively high levels of social expenditure. There were political tensions, especially around housing, with over 10,000 people in emergency accommodation in November 2019, and around healthcare capacity and the cost of living. However, there was no notable right-wing populist or libertarian presence in Parliament before or during the pandemic. Trust levels in political institutions, law enforcement, and the legal system were relatively high by European standards, though lower among those with less education. Economically, the pre-pandemic picture was broadly positive. Following a decade of austerity after the 2008 crash and the IMF bailout, the economy was growing rapidly. Government finances were healthy with a small budget surplus and declining national debt relative to GDP. Poverty risk after social transfers and the Gini coefficient were both below the EU averages. Educational attainment among adults aged 25 to 64 was well above the EU average. At 13%, the proportion of people aged over 65 was relatively low compared with other European countries. Urbanisation at roughly 63% of the population was below both UK and EU averages. Less favourable in terms of virus transmission. The proportion of single occupancy households at 28% was also below the UK and EU averages. Of course, these national macroeconomic indicators conceal major socioeconomic inequalities at small area level, shown here for the country as a whole, using the Hubble census derived deprivation index, and here at city level for Dublin. In this context of socioeconomic deprivation and vulnerability to coronavirus infection, we must also consider the traveller and Roma communities in Ireland, with estimated populations of approximately 40,000 and 16,000 respectively. Both communities, as we know, experience racism and discrimination with overcrowded and unsafe accommodation conditions, barriers to education and employment, heavy burdens of illness and life expectancy well below that of the general population by about 10 years for women and 50 years for men. Immigration in Ireland had plateaued in 2017 following an upward trend from 2010, and the majority of immigrants were returning Irish citizens are from either the UK or the European Union. However, by 2019, the direct provision system for asylum seekers was under intense pressure following a 16% rise in applicants. More than 6,500 people who were in the system, with widespread use of emergency accommodation, and the system faced heavy criticism for violating rights to privacy and dignity due to overcrowding and lack of personal autonomy. Life expectancy in 2019 continued to rise and remained above the EU average, albeit with the 5-year gradient across deprivation quintiles. About 83% of Irish adults who reported being in good or very good health in 2017, the highest proportion among all EU countries and sub-Saharan substantially above the EU average of 70%. Even in the most deprived areas, over 70% of adults reported good health. On a less positive note, Ireland had high rates of obesity and binge drinking in adults relative to EU averages in the period before the pandemic, both important risk factors for COVID-19 susceptibility and severity. Turning now to Ireland's public health infrastructure, our capacity to deliver on essential public health functions. In 2019, the public health medicine and communicable disease control infrastructure in Ireland was structured around 8 regional departments of public health in a National Health Protection Surveillance Centre supported by a computerised infectious disease reporting system and a national virus reference laboratory. However, the system was highly fragmented. There was a clear governance divide between the 8 regional public health departments aligned with historical health board areas, 7 hospital groups, and 9 community healthcare organisations, each with separate budgets and largely independent management structures. The Faculty of Public Health Medicine oversees a respected higher specialist training programme, and academic units in Dublin, Cork and Limerick provide MPH and doctoral level training. Galway has a dedicated health promotion department, and UCC has offered an undergraduate public health sciences degree since 2004. The All Ireland Institute of Public Health, established after the Good Friday Agreement, contributes to policy and advocacy. However, we lacked the political and institutional structures needed for a coordinated all-island pandemic response, something that must be prioritised before the next pandemic. The 2018 Carworth report identified the need for a national public health strategy, consultant level appointments for public health physicians, and major investment in multidisciplinary public health teams. Unfortunately, these recommendations faced resistance within both the HSE and the Department of Health. I can attest from personal experience that scepticism about consultant level appointments was widespread. These appointments were only conceded during the pandemic and only after public health physicians threatened a national strike. Thus, pre-pandemic public health physicians were demoralised, and there was a large number of imminent retirements. The limited profile and visibility for public health specialists posed significant recruitment challenges. Many regional public health medicine departments were located in unsuitable buildings with lack of space, in adequate IT infrastructure and support, and were still using paper-based contact tracing systems at the onset of the pandemic. The broader multidisciplinary team was and remains small in the regional departments, and there is no defined career structure for multidisciplinary team members. In UCC, for instance, we have graduates with a BSc in Public Health Sciences, MPH and PhD in a relevant public health discipline, who have no option in regional departments but to accept appointments at administrative grades. We entered the pandemic without individual health identifiers, minimal progress on electronic health records, and a highly restrictive and legalistic interpretation of EU GDPR legislation. While there is now finally some movement on health identifiers, and indeed there was some innovation during the pandemic, progress on our national data infrastructure is painfully slow. Pre-pandemic, there was limited capacity nationally in infectious disease epidemiology and modelling, and although we were well served by a small group of individuals with high-level statistical expertise, there was no national centre drawing on the granular expertise that comes from fieldwork and analysis of large-scale epidemics. There was and still is limited integration and collaboration between service-oriented and academic public health units, with no substantive joint appointments in 2019 at professorial or senior lecturer level. The available infrastructure and capacity in public health is highly fragmented, with minimal pooling of common administrative and technical resources, and missed opportunities to achieve economies of scale. For example, in Cork, a city with a population of just over 200,000 people, I have listed here 5 units with a population health focus that are all based in separate locations across the city. In summary, as an island nation, wealthy, politically stable and technologically advanced, with a Taoiseach who was medically qualified and a well-educated and politically moderate population, and a relatively favourable demographic profile, Ireland should have been well placed to respond to the COVID-19 pandemic. Unfortunately, despite high per capita spending on health, we underperformed at health system level, with significant consequences for morbidity, mortality, and the societal impacts of prolonged lockdowns. Failure to invest in Ireland's public health infrastructure over several decades contributed significantly to these outcomes.
Thank you very, very much, Professor Perry. And I think it really speaks to some of the issues in terms of what the evaluation panel has to do in terms of really focusing on preparedness and lessons for the future. We're going to stay with the Irish health system. Our next expert is Professor Mary Codd, who is Associate Professor at the School of Public Health, Physiotherapy and Sports Science at University College Dublin, as well as speaking to the overall response, including the test and trace programme that she led at UCD. Professor Codd also has great insights into our health infrastructure and the social and cultural factors that may be relevant and indeed are relevant in a public health crisis. So over to you, Professor Codd.
Thank you very much. So my contribution will be based on practical, on-the-ground experience as director of the UCD Contact Tracing Centre with medical and epidemiological and public health background. And we ran that centre from the 17th of March 2020 until September of 2021. This was one of 9 centres set up with great speed, it has to be said, in one day, around the country, at least in our case, one day, mostly in academic institutions, to assist the HSE and the public health workforce in contact tracing. And that, as a growing task, had become impossible for the public health workforce of the day. We had one advantage, and that was that this ended up being a centralized system, and that was a strength, where the individual centres all were convened every morning, 7 days a week, over the entire period, where we provided feedback on the work we were doing, the issues we encountered, the changes we were then informed about, changes in policies and procedures. And in that regard, that was good. What was not so great about that was that the public health operational workforce, as my colleague Ivan has referred, were not part of that. In fact, there was a separate meeting each day with the public health people. And in fact, I was the only person that bridged that gap between management and public health. There were a lot of issues that were discussed, that arose in the management meetings, decisions being made which were of public health importance, and yet there was not a public health voice apart from one to say, no, we cannot do it this way, we ought to do it that way. So I would immediately identify the lack of joined up thinking despite a small country and a manageable handful of contact tracing centres. However, I will deal with some detail in relation to test and trace, which is what I've been asked to address. Fundamental to contact tracing are the results from testing. We had one site initially in the country, the National Virus Reference Laboratory, which very quickly, when we woke up to the fact, I'll come back to decision making a little later, when we woke up to the fact that we needed to test for COVID-19, this one centre, the NVRL, with limited capacity, quickly became completely overwhelmed. The time from testing to results increased day by day. The wait time for results from a contact tracing perspective became quite ridiculous in that we were wasting our time contacting people when we got results 10 days, 2 weeks after the test. It got even worse as the numbers increased through March and April and on into May of first wave, with the exporting of samples to Germany for testing, whereupon it was now going to be 3 weeks, and frequently was, before information entered into our national system suitable for contact tracing. I'm on record on prime time, sometime in April, as saying, if we don't reduce the timing of the results of testing to 48 to 72 hours, we're wasting our time. And even that, I recognized at the time, was still a waste of time. We needed results within the day, or at least within 24 hours. Eventually, that was solved. I mean, on the good side, we were in a position to have an immediate response. However, that response was saturated very, very quickly, and there was really failure to recognize the speed with which we needed to upscale and upgrade our testing system. We had animal facilities that could be employed. It took 6 weeks for the suggestion of employing and commissioning facilities which were available, which were private facilities, which required contractual agreements and payments, but it took 6 weeks to negotiate that. And it was April of 2020 before those facilities became available and before what we were trying to do with contact tracing became in any way effective. Still on the testing, I'm going to switch to the long-term residential care facilities. I hear with great interest all of the things that have been said by our colleague in Sweden and Scotland in relation to long-term residential care. The issue with transmission of COVID in the long-term residential care facilities in this country was identified very, very quickly. I can pinpoint the day when we contacted Central Public Health to say there is an expanding issue. We have had so many cases in such and such nursing homes in the eastern region. We became the centre responsible for making contact with all of the nursing homes in the east and northeast and many other parts of the country. In fact, a total probably of about half of the nursing homes in the country. I don't need to say to this audience that we have here vulnerable populations living in close quarters, using communal areas, communal equipment some of the time. We had an immediate issue in those facilities with personal protective equipment for the staff. And it emerged over time, and I'm going fairly quickly now, that infection prevention control training in the long-term residential care facilities was seriously missing or substandard. We have two very cogent sources of evidence for that. A study that we carried out in the middle of 2020 when there was a lull of 400 healthcare workers, where we inquired about their training prior to, during, and after the first wave. And it turned out that less than 50% of our long-term residential care facilities had training in infection prevention control prior to the pandemic. Quite a bit less than 50%. And the remainder then instituted it either during or directly after wave one. This is despite having national recommendations in relation to infection prevention control, which I've discussed in great detail with the then head of the national guidelines, and where we needed to agree to disagree, as it were, on the implementation of those guidelines and put it down to behavioral aspects or regulatory aspects or oversight aspects or training aspects in the nursing homes. And of course, the other thing about the nursing homes in particular was that of all the places we contacted, well between probably about 300 over the time and repeatedly, not a single one had isolation facilities. They operated at capacity with skeleton staff that was then further compromised by illness from time to time. So it leads me on to decision making. And perhaps early on in January, it took us until the end of January for the National Public Health Emergency Team to convene. I have a feeling that perhaps we thought as an island nation, we might be slightly protected from the ingress of COVID here. Maybe our colleague from Scotland, you had some similar thoughts. But we didn't take account of the global reach and the international travel that had changed hugely in 20 years because we had successfully managed to keep foot and mouth at bay in 2002. So the only strategy that was implemented in the long-term residential care facilities was testing, blanket testing. That was not implemented until almost the end of April. And at that, the ambulance service were mobilized. Despite being prompted multiple times, it took that length. This is why I think that decision-making on public health front and also on other fronts needed to be speeded up quite a lot. We dragged our feet in terms of decision-making. If I can now quickly move on to the tracing. we were wholly unprepared to undertake any aspect of contact tracing. The existing public health workforce was quickly overwhelmed, even with the help of Army cadets who were brought in and trained to do very basic contact tracing. And it was quickly overwhelmed in the very first half of March of 2020, which is why by St. Patrick's Day, and we had just gone into lockdown, the academic public health centres were asked to engage. There was no infrastructure in terms of IT. In the space of 1 week, a customer relationship management system was commissioned. It was totally unfit for purpose. What it was a customer management system, and the modifications to that to be suitable for the deposit of test results from the testing centres took place in real time. It delayed everything. It was incredibly time consuming. It was cumbersome. Changes grew from the ground up. In our own centre, we had an entire group of Master of Public Health students who turned their attention to upgrading and changing the IT system to make it fit for purpose for medical reasons. The workforce, there was no workforce, apart from public health workforce, which I mentioned was quickly overwhelmed. In a very short time, we were able to garner the support of volunteers. They were our colleagues in the academic centres who stepped up to the mark quite literally overnight, and for 6 months worked voluntarily. In fact, they also felt they made their contribution. And to Mike's point about engaging the local community, they all came from the local community. They felt that they were making a contribution and they were valued. And I do think this is something that we have not capitalized on, and I'll finish with that very shortly. There were redeployed healthcare workers, from the environmental health officers to the senior medical officers and other specialists who, of course, then were compromised in terms of their normal day-to-day work. There was a certain lack of integration, even in the revamped IT system. There were groups who just did not interact with it, including, it has to be said, public health trainees were not trained to use the system, despite the fact that we did try. Occupational health departments in hospitals did not use the system. So we frequently found that we were duplicating effort by contacting people who had already been contacted that day or the day before. So there's a lot of joined up thinking that's needed. The training of the workforce happened in real time. There were no materials. Revisions happened on the fly. As I say, people were volunteering until October of 2020, when Department of Health, government, or whoever, and you've heard about our profile at that time, agreed that we needed a paid workforce. And then they were employed at a very lowly level, either as level 1 or level 2 tracers, and making a case for the expertise that had been developed over that 6-month period was actually quite a big ask. There was confusion, already been mentioned, about the very frequently changing guidelines, though in truth, I think that perhaps some of the guidelines were extremely good. But we had an assembly every morning to appraise our tracers of changes that had taken place in the preceding overnight or preceding day, and sometimes even twice a day. And we used to say, if you're missing for half a day, you're out of date. There were unanticipated events that emerged over the course of and the experience of tracing. We never anticipated, no one anticipated the potential for erroneous results, false positive and false negative results. It happened within 1 month of us starting contact tracing. There were positive tests on people who had died, which was extremely distressing for family members. We had the variants of concern, the flights of concern, the mandatory hotel quarantining, all of which required inaction at the time, revisions and updates to guidelines and development of protocols and scripts for contact tracers. And the contact tracing was, I think, misunderstood in terms of its degree of complexity. It was not simply making a call to people to say, this is the result, now you need to do the following. The vulnerable groups continue to emerge, whether it was long-term residential care facilities, seminaries, convents, asylums, asylum seekers, homeless populations, travellers, health workers, meat factory workers, bakeries, farms, migrant workers, those living in close living quarters unable to isolate, and of course the care of elderly at home and children. Then we move on to, more complex situations like repeat positivity, the impact of vaccination. And one of the things I would say is that we needed much more information from our testing, and we needed to know a lot more about cycle times and things like that. So the good thing is that the workforce that developed over that time in a piecemeal fashion as needs arose became a very expert workforce. We've not acted on capitalizing on that workforce and that expertise. There is an opportunity there to develop a stand-up, resilient workforce that we have not capitalized on. And it's now 6 years to the day almost when all of this took place. So one final word, and that's on outcomes. Generally, we did well to some extent, although there's some indecision about the validity of it. We did well in part because those in the older age groups did cocoon at home. And I want to put out a figure here. It's frequently said that age is a risk factor for mortality from COVID. Age is not the risk factor. It's what comes with age. It's the comorbidities. Those over 70s who cocooned at home, mortality in that group was no different, no bigger than mortality in the general population. However, we looked at and analysed the data from an age-matched group in residential care, in congregated settings. Mortality in that group, age-matched over 70s, was 21 times higher in the residential care facilities in this country. With less than 5% of the population in nursing homes, we had 60% of the mortality in wave 1 among the residential care population. So there are a number of factors we have not yet addressed. I've mentioned the workforce factor. We have not addressed adequately the residential care facilities factors. We have not addressed occupancy, staffing, remuneration, rotation, training, infection prevention control. It's improved, isolation facilities, oversight and regulation. And those are lessons that have been learned that we need to act upon. Thank you.
Thank you very, very much, Professor Cotton. Just to say, just to remind everyone that the evaluation will be taking a model that will be dedicated to the response in long-term residential care facilities for older people. But thank you for your contribution. Finally, in this second grouping, we're delighted to hear from Professor Anthony Steens, who's from the School of Nursing, Psychotherapy and Community Health at Dublin City University. Professor Steens will be joining us online. And just a reminder to all of our participants, we do have time pressures. We do want to finish up within the requisite time, so please, if you could stay to your allocated things. But for now, Professor Steens, you're very, very welcome.
Thank you. I knew I was going to be the last speaker in this session and time is going to be short. So I'm going to say 3 things. The first is, what am I most ashamed of that happened to me during the COVID pandemic? At the time of the pandemic, I was the chair of St. Michael's House, which is a large intellectual disability support service. And unlike most other support services, where we provide residential care, we provide it in ordinary houses. So typically we have somewhere between 3 and 5 people requiring support in our residential facilities. And the majority of our users are living at home with family or in other caring arrangements. And we spent an enormous effort keeping that group of people safe, including a memorable occasion when we acquired large amounts of PPE from a van in the back of a car park. But I was concentrating so much on this group that I never thought about nursing homes. And I didn't think about nursing homes till the work of Mary and people like her suddenly pointed out that this was an area that was a serious problem. The second thing I would say is this: very little has changed. The IT systems in the Health Service Executive are still disorganized, out of date, unbelievably slow to deliver. There is a maternity and children's health module, which may just now have been delivered to the last hospital. I'm not quite sure, but it's taken over a decade to roll it out. There is a tender process now for an EHR for the rest of the system. And the current betting is that the winner will be a system unconnected with the current system. How we're going to connect these two, we don't know. We don't have workable ICT interconnects with laboratories. There is a plan for 18 years to build a laboratory information management system, which has not worked. We have got a superb system for radiology, NIMS. There are one or two hospitals not part of it yet, but almost all the Irish hospitals use the same system. So it's possible to transmit images and diagnoses. We don't have working patient identifiers yet. They exist, but they're not out there in the wild. And that is a major shortcoming of the system. And it makes it very, very difficult to do a lot of the stuff that is very, very basic. My first post-PhD job in the UK was working at the small area health statistics unit. And we are only now in a position in Ireland where we could replicate some of that work. The model of NPHET, which remembers National Public Health Emergency Response Team. NPHET is not a good model for managing a pandemic. Its intended purpose, and is pretty good at this, is to manage things like the public health response to chemical spills, the public health response to environmental disasters of some kind or another. And I would say that NPHET has done that quite well on several occasions. What people may not realize is that NPHET was stood up from scratch every time it's set up. It was tolerably clear by the end of the pandemic, when I think NPHET had 50 members. You can't run a committee with 50 people. It's not possible. And I speak from considerable experience running committees. The most disturbing thing about NPHET was that from early on, there was no one on it with serious epidemiological experience. And in particular, there was no one on it with infectious disease epidemiology experience. So people were on NPHET were receiving models which they didn't really understand. And they were doing their best. I mean, everyone on NPHET that I know worked flat out for the pandemic. And as Mary and Dan have pointed out, we got large parts of our response to it right. We also got parts of our response wrong. And that was one of the reasons, not the only one, but it was one of them. Finally, the question of what happens when there's another pandemic? Are we ready? And the answer to that is absolutely not. We are not ready. We haven't learned from everything that went on in COVID. And remember that before that, the last human pandemic that affected this country was in 1969, which is neither today nor yesterday. But there is good evidence that pandemics are likely to become more frequent as a direct result of climate change. So if we are to cope with another pandemic, we need to do a great deal of work on the public health workforce, on information systems, on laboratory systems. One of the things we discovered in the course of this was that cider had a weekly limit on how many cases you could put in. This is not the kind of thing you want to discover in the middle of a pandemic. And it's clearly insane. It's completely unacceptable that that kind of limitation even exists. Never mind that it caused the problems it did. So, we've always had a problem in this country recognizing the importance of public health. The majority, if I had gone into any other line of work besides the one I did, I would now be a consultant in public health as well as a senior academic, which I am. But there has been immense opposition to the consultant grade in public health, opposition which I think has no rational basis. But if we are to reform our pandemic response, we have to get our public health workforce right. We have to get our plans and policies right. And as Mike said, and I think this is really, really, really important, one of the guiding principles of my work for 30 years has been nothing about us without us. And while that phrase was originally coined to describe work on people with disabilities, it actually applies to this kind of work on the population. We need to figure out ways of bringing in the public. We need to figure out ways of keeping and holding the public trust. And we need to figure out the skills to do that. And they're in relatively short supply. So can we get ready for the next pandemic? Yes, of course we can. We just have to want to enough. Did we do okay this time? We did okay, but only okay. Quite a lot of countries did better than we did. A large number of countries did substantially worse. So Ireland can give itself a very half-hearted pat on the back for a pandemic response. We must acknowledge that we may need to do better next time because we don't know what the next pandemic will be. We do know that it will, whatever it is, it will surprise us. Thank you.
Thank you so much, Professor Steams. A half-hearted pat on the back, and your contribution really sets us up for our third and final grouping, which is looking at how the evolution of the pandemic interplayed with that broader health system. How did it impact services, capacity, and infrastructure, and how did we cope in respect of the wider health and social care services, including reaching those all-important local and marginalised communities? Our first expert to share his insights on the interplay with the health system is Professor Steve Thomas, the Edward Kennedy Professor of Health Policy, Public Health and Primary Care at Trinity College Dublin. You are very, very welcome, and the floor is now yours.
Thank you so much, Devil, and thank you so much to everybody for your analysis and insights given so far. It's been really fascinating and important. And so I'm going to be focusing on 4 different aspects. I'm going to be looking at preparedness of the health system. I'm going to be looking at the health system response, then legacy issues of what we are left with, and then finally some reflections on where we go from here. So I think the first point to make is we weren't ready, we were not prepared. And that looks, the two different aspects to that. Our health system was stretched and actually hadn't fully recovered from the austerity years. Our bed numbers were low, the third lowest in Europe in terms of proportion to population. Our bed occupancy was very high, 90%. We had fewer primary care and community staff in 2019 than we had in 2008. And we had high numbers on waiting lists, which meant that we didn't have much flexibility. I think then when it comes down to actual COVID and our preparedness for that, our ICU bed capacity was low, PPE was in short supply. We hadn't really done scenario testing around the COVID pandemic, and Mary mentioned earlier about the lack of contact tracing architecture and not really linking in with the residential care facilities, which we would have done if we'd done the preparedness right. So we went into a lockdown really to protect our health services from the kind of catastrophe that we were seeing in Italy and in China. Having said all that, having said that we weren't prepared, we moved quickly and we got a lot of things right. And this is where I actually contest with Professor Perry that we underperformed. I actually think we did perform well, even though we weren't very well prepared. I think we boosted funding, workforce and capacity to meet the challenges. In 2020, we had an extra 2.4 billion put into the health system for COVID-related costs, including treatment, testing, PPE and provider support. In 2021, another 1 billion for beds and community services and schemes to reduce waiting times. As one health system leader said at the time, we gave the system rockets. We made all COVID-related care free and reducing out-of-pocket costs and the barriers to accessing care. In terms of the workforce, we had an increase of over 10,000 whole-time equivalents from 120,000 to just over 130,000 between December 2019 and August 2021, including over 2,900 nurses and 1,000 doctors. We obviously had to be flexible, and we demonstrated that, although it was obviously quite tricky. Even in April 2020, we had 3,500 community staff redeployed onto COVID activities. And that meant we were certainly able to meet some of the challenges that the COVID provided, because we were looking at providing COVID treatment care, test and trace, in-time vaccinations, as well as trying to run the system. So there's 4 different areas of strong demand. And we managed the ICU bed situation, increasing critical care beds from 256 to 348 in January 2021, where our critical care occupancy was 95%. So that was cutting it fine, but we just made it through that. We took over private hospitals temporarily, but just in case. And we developed new arrangement with the private hospitals to deliver care that actually extends now to the current day. So we did a lot. We moved fast, but I think there are 2 key legacy issues that actually we have to deal with, and unless we deal with them, they will become our preparedness for the next crisis. And one of them is waiting lists, and the other one is demoralization of staff. And I think on waiting lists, we see quite a lot of pent-up demand from COVID. A lot of people weren't able to get the care they needed within COVID, just for the things that the health system has to normally meet. People didn't want to present because they feared getting infected, and people in the system, they weren't processed as quickly. So what we saw at the end of the crisis, and actually what you see often at the end of any major crisis, is a huge increase in demand for care services. We saw the same thing after many years of austerity. So people coming into the system post-COVID in the aftermath, and then there being a need to actually maintain the funding in the healthcare sector and the provision to cope with all that pent-up demand. And actually, not surprisingly, we've seen waiting list pressures increase, waiting lists go up. And that we've got to be careful with that. Unless we deal with that, that then becomes our starting point for the next big crisis. The other key point I would say is obviously demoralization and burnout of staff. Staff went above and beyond the call of duty. Over 2 or so years, workforce resilience was tested by long hours, stress and burnout. And various surveys in 2021 showed that there were increased mental health issues and burnout reported amongst very many doctors, nurses, midwives. Staff turnover doubled for some cadres between 2018 and 2022 and increased in all categories. And during COVID, according to one survey, 68% of nurses considered leaving. So these are key issues. And I think particularly when you get the cost of living crisis after the pandemic, more and more pressures being put on the workforce that need to be defended. And I think this is a common problem across high-income countries, not actually looking after and protecting the workforce as they should have done. And I think many countries and WHO have put their hands up over that. One of the things that we did well, though, particularly well during the crisis, was we leveraged it for reform. And we had a reform program in Sláinte Care. We certainly enhanced capacity in the health system. And sometimes a crisis is a good time to make changes. It's a good time to invest because there's much less opposition and people can see the value of healthcare. So we gave the system a taste of universalism. We dropped user charges. We accelerated some of our digital innovations like teleconsultations and virtual clinics. And also I think we removed some of the top-down control that had been very much baked into the system from austerity. We said, here are the resources, go fix it. So I think just finally, just wrapping it up from my side, I think a resilient health system requires proper preparedness planning and scenario testing for effective governance to build capacity, to build relationships. We didn't have that. We had to do that as we went along. We have to deal with issues from previous crises, the overhang, the legacy. That will mean we need to watch out for our workforce now, and we need to bring these waiting lists down. We need to make sure that is a key issue, just looking after the workforce. Adequate funding and universal access is, I think, also key requisites for going forward, and obviously enhancing our digital infrastructure and telemedicine. So I actually think our health system responded well, but I think if we'd had better preparedness, we'd have avoided a lot of the mistakes that we did make, and we wouldn't have had to make decisions so quickly. And inevitably, some of those go wrong. And that may also have then, if we'd had better preparedness, that may then have allowed us a less stringent response too.
Thank you very, very much, Professor Thomas. As Professor Thomas outlined, services during the pandemic were and perhaps remain a significant issue, but we're delighted to next invite Professor Patricia Leahy-Warren, Professor of Nursing and Chair of Health Services Research and Dean of the School of Nursing and Midwifery at UCC to address the roundtable. You're very welcome, Professor Leahy-Warren.
Thank you very much, Derval, and thanks everyone for the opportunity. And really, I'm here to speak on behalf of the directors and assistant directors in public health nursing across the country that I have been able to communicate with over the last number of weeks. So my central key points really are to reflect the frontline experience of them, highlighting system strengths, gaps and lessons for future pandemic preparedness, as everybody has outlined here this morning. So PHNs remained fully operational throughout the pandemic, often as the only consistent face-to-face community service. They played a critical role in the COVID testing and vaccination because they were redeployed. They were also redeployed into nursing homes where predominantly they were private, and they very quickly ran out of staff in terms of sickness, either COVID or otherwise. They also developed public health lines, and they also were engaged in training in infection prevention and control. So this rapid implementation really had an effect on their workload. So they reverted to their prioritization framework, which really was virtual consultations and only alongside essential home visits. And a lot of those were actually outside of the home as opposed to in the home. There was different models around the country depending on the infrastructure and the community engagement and collaboration, where GP practices worked very closely with PHN services. They did split teams. So they did the A and B model to reduce infection control, one who were engaged in home visits, one that were engaged in the community continuity of care where possible within the health services. However, there was major service disruptions. There was suspension or reduction of child health programs, developmental checks, school immunisations, which resulted in significant backlogs, tripling of vaccination cohorts in some areas, delayed identification of developmental and postnatal issues. And then there was workforce pressures and system strains, which my colleague here has also referred to. There was high absenteeism and redeployment, cross-coverage of large geographical areas, early retirements and limited full-time capacity. So therefore, there is continued and recognition of PHNs as frontline staff. Childcare and practical supports was an issue where it wasn't maybe for others who were able to work from home, and compensation for extended work hours. There was then suspension of the non-COVID services led to the reduced clinical skill maintenance, which continues today, delays in service development and staff training. So significant efforts are required post-pandemic to restore competency and address service backlog. System fragmentation, variable engagement again from the GPs, allied health professionals, often those were redeployed as well, as Professor Cott has just said. Specialist community services were reduced, as Professor Haynes has just said, and there was increased reliance on PHNs where other services were reduced or in fact closed. Then there was the psychosocial and ethical impact. There was increased isolation among older adults, vulnerable families, restricted visiting, including end-of-life care, and long-term emotional and societal consequences. The recovery burden. PHNs carried the post-pandemic recovery workload, also included large-scale catch-up vaccination programs. The child health screening and development is still ongoing, and therefore this ongoing service demand and new system reforms and programs are warranted in terms of increase in numbers of public health nurses, which are quite low in numbers across the community care services, and the majority of those being women are also working in a less than full-time capacity. Thank you very much.
Thank you very, very much for that, Professor Leahy-Warren. One of the strongest themes that's really come across today is the importance of social inclusion during a public health emergency, and we're delighted that our next expert, Dr. Patrick O'Connell, has incredible insights as a GP who can speak to this issue. He's also Associate Professor and Inclusion Health GP for HSE Midwest, a teacher and a researcher at the University of Limerick School of Medicine. Over to you, Dr. O'Connell.
Thank you, and thanks for having me today. So I've got two hats when I'm speaking here today. I wasn't involved in the national decision-making around what's been discussed, but I was an end user, if you like. The decisions that would be made on a daily basis, we'd be faced with implementing the next morning in busy clinics on the front line. I also have another hat where I'm involved in a broad team in managing and delivering health services for marginalised and vulnerable groups in social inclusion and HSE Midwest. So I saw the pandemic from both sides. So we start with general practice. General practice was a key part of the Irish response to the COVID pandemic. There was this additional COVID response work, all the while trying to maintain core work of chronic disease management, screening, antenatal care, childhood vaccines, and keeping our patients and staff safe from this unknown. It was a time of great professional uncertainty, but also personal concern and worry for every single person working in every single GP practice across the country. I would say, in hindsight, it was a time of great dynamism, collegiality, I suppose, where there was a real can-do attitude. And I'm going to just give some examples of that today. So what changed, and in some instances changed overnight, was things like practice redesign. So having zones within small, country practices, rural practices, where people with symptoms would be seen or dealt with. Appointments only, so the era of walk-in appointments in general practices across the country, which still existed in some settings, was pretty much gone. Phone calls, triaging people before they came in, having discussions with them about symptoms before they ever came through the door. Social distancing, masking, no shaking hands. I was looking through emails this week from the college and from the IMO, and there was a bullet point on one saying handshaking with your patients is gone. For now, PPE, obviously kind of barriers and the concerns around that. Our waiting rooms at times shifted to asking patients to wait in their cars. Don't come in, we'll call you. The shift from face-to-face consultations to telephone consultations and trying to manage and run services where we rely so much on sitting down with the person and working through things. Electronic prescriptions came in a very short space of time, again, to reduce footfall in practices. The old paper prescriptions were no more. Also, then when you look at the COVID-specific roles, if you think back to the earlier stages, in terms of triage and case management and symptom discussion with patients who are often terrified in the early stages, they're hearing all of this in the news and from the announcements every day, and now they've got symptoms, and you're kind of engaging or interacting and trying to talk people through. At the early point, it was deciding on the need for testing. So through our practice management systems, making referrals, advising on isolation and home management. And also on top of that, many GPs did take up work in COVID hubs, so COVID assessment hubs that were run in collaboration with the HSE. So I was describing earlier to Professor Woodhouse the arrival of vaccines in general practice. There was a sense of euphoria in that early days of February when the vaccines arrived, and we really felt that this was something tangible we had in the practice to offer our patients to try and turn the tide. We were also involved in the certification and the kind of risk categorization of groups for the vaccines as they were rolled out more widely. Behind all of this, there was a huge effort on behalf of the Irish College of GPs and the IMO in terms of upskilling and educating and keeping every GP and every practice nurse and every practice team member across the country upskilled and updated. There was webinars maybe 2-3 times a week on various topics in relation to this. So what were the impacts? So consultation, the number of consultations and subsequent research that's been done remained high. The mode and how they were conducted and the content, the topics that were discussed were slightly different. There was obviously an initial reduction, as has been mentioned by Professor Thomas and others, in routine care and preventive care, but then that increase, that rebound in terms of the workload with that deferred care and the issues that people had maybe been sitting on for a while because they didn't want to trouble us or they were afraid of coming in. The case mix, so obviously an increase in discussions around respiratory issues, but also mental health issues. And it's very difficult sometimes to remotely engage with somebody around mental health issues, even if you know them for a prolonged period of time. Complex multimorbidity, trying to manage kind of the intersection of illnesses. Again, it's much better done with the practice nurse, the GP, the patient, all sitting down together to work through things. There was times of financial uncertainty for the international audience and speakers here. We have a mix in terms of general practice in Ireland where there are kind of public and private patients. So in terms of the private engagement with private patients, that would have decreased quite a bit. So there was concerns for practices in terms of that. Access and continuity to a degree were preserved, but different. And we really quickly noticed that some of our patients of older age, some of our patients with limited literacy, a lot of the systems that were developed really quickly were text message systems or online portals, or I suppose they were designed for the middle ground in the fastest way possible. So we became acutely aware of those gaps. And finding kind of ways and routes around that. We were obviously seeing and hearing and I suppose bearing witness to increased stress, anxiety, depression, isolation, people who had really worked for long periods on their own and not met many other people, and it manifesting in terms of their health and mental health. Financial uncertainty, bereavement, long COVID, and I suppose all of this was coming out over time. When you look at the general practice across primary care, the workforce, in terms of that uncertainty, going into work every day, knowing that I need to check the HPSC guidelines that morning, and at lunchtime, like as you said, I'd be out of date by the afternoon if I didn't. The guidance changes and trying to keep abreast of everything that was happening and the high workload. So the other part that I mentioned was in terms of the inclusion health and the social inclusion type approaches, focusing on underserved, marginalized, vulnerable populations. So some of the characteristics that have been mentioned already, things like precarious accommodation, sporadic contact with healthcare services, or limited trust in services, poor experiences with authority or services, addiction challenges, language barriers, I suppose, creates a perfect storm in terms of trying to manage. But what we found, particularly in the Midwest area where I work, is we knew the patients from many of these groups. We had experience in addiction services, in traveller health programs, in homeless health programs, in working with people. We knew people really wanted to follow the advice. We knew people were really keen to protect themselves and everybody else in hostels, but also the wider community. So what we had to do was work with the National Social Inclusion Office, other GPs and our public health specialists locally. I remember at the early stage, Dr. Andy, who's a public health consultant in the Midwest, she visited all of the congregated settings, the homeless hostels, the halting sites and other areas to actually get a grasp of the challenges that were to come in terms of advising to contact tracing, or to actually go and physically visit and document in detail what the context was before the storm. We also had early engagement. We established our own swabbing and trained up multidisciplinary team members, administrators and others to do swabbing, so that we were able to proactively go and do that in tents, under bridges, in domestic violence shelters, on halting sites, and being able to manage and support patients, remove some of that fear. We also provided our own vaccinations. So what we did was, I suppose, adapting what was being done in the mainstream and contextualizing it, bringing it out, removing some of the fear and mystery about it, and delivering it by people who were familiar to the service users or patients we met. We had our own social inclusion specific isolation services run by experts in harm reduction and key work. You have people who have a dependence on substances and may have co-occurring mental health issues, and you're asking them to isolate in a very kind of a controlled environment. So on a case-by-case basis, we were able to do that, and there was little or no kind of outbreaks, and there was huge engagement and buy-in. So in summary, I suppose the localized adaptation of the national and international guidance, I suppose being given latitude to adapt that on the ground was to me a huge success. There were things across both settings that worked well. That was adaptability, continuity, for the best part, trying to maintain that. The vaccine delivery piece, the IT changes, that upskilling, education, guidance, that kind of rapid rollout of that. And to me, look, I know communication between the front lines and kind of up and down the system is imperfect, and it's going to be imperfect. But to us, from my viewpoint as a GP, we felt like concerns around PPE, our vaccination, and kind of the timing and rollouts, they were being brought to the national level, and they were being listened to and heard. What things didn't work well? Obviously, it's been mentioned around deferred care and people having a real fear of coming back into our practices to deal with things that we need to. Inequity across the board in the way services are designed for that middle ground in terms of literacy, language, some of the data capture around that as well in terms of ethnicity or other, I suppose, social exclusion characteristics. I'm not sure how well they were documented at the time in the interest of doing things in a speedy way. And then just looking at our workforce, it's been mentioned in terms of support for burnout, and the well-being. Thank you.
Thank you very, very much, Dr. Donald. A lot of our contributors and experts today have spoken about the importance of context. I think you've added a very good addition to that, which is the importance of understanding the context before the storm. I think that is something that will resonate. Last but not least, just for our individual expert contributions, we're going to hear from Professor Sarah Burke, who is Associate Professor and Director of the Centre for Health Policy and Management at Trinity School of Medicine, and who is also an expert to the independent COVID-19 evaluation panel. And Sarah, looking forward to you capturing some of the insights from this morning in respect of the health system resilience and challenges.
Okay, good morning, Devlin. Thank you. A lot has been said already, an hour and 52 minutes, so I'm sort of scrapping my notes and I'm just going to try and add a bit of added value and keep it brief in the interest of time. I think the Ireland did well statement by a few, and it was my top line in my briefings for myself coming in today, is all, as Anders said, in the relative to the context, relative to us coming in with a very low, fragile public health medicine infrastructure, so decades of underinvestment in population health and prevention, but also a fragile, fragmented, complex health system. So given that context of Ireland, I think we came out of it well. When you look at those headline indicators that are used internationally of excess deaths, of uptake of vaccinations, of adherence to measures like that, where our mobile phone tracks us, like we all stayed at home, like we were very compliant. So I think that's an important context that we did well within that context. And that there are then, as Ivan outlined, pre-pandemic, but even now, post-pandemic, if we're allowed to say that, we do have higher levels of trust in most institutions when we compare ourselves across countries. I think it is important to bring ourselves back to, I always think it's extraordinary, we had a general election on the 8th of February 2020. And I always sort of monitor the elections from a health system or health policy context coverage. There was no mention in that election of the coronavirus. It wasn't even on the agenda. It was something happening in China. So I think that's an important context, that it wasn't on the political or the ordinary. Most of our population members, Steve and I had a meeting with the then head of the HSE in Trinity, and he spent the whole time out of the meeting on his phone to the chair of the HSE board because they knew what was coming. So just that context is important. And I think that also sets, that sort of political context, sets the scene for our response, in that we do live in a relatively healthy modern democracy where there was political consensus that's by and large supported the evidence and the public health measures. And particularly, obviously that was important then, but it's particularly an issue in the world we live in today. And that by and large, there were many faults and we did lots of things wrong, but by and large, we had a coherent whole of government response throughout the pandemic. I could obviously spend my time picking all the holes and gaps, but I won't. I think it is also important to say, though, because obviously as working with the COVID evaluation panel and just going back through the submissions from the public and key stakeholders in preparation for today, you know, the pandemic particularly impacted people whose lives were precarious before the pandemic. And it really did impact. It impacted particularly on carers, and most carers tend to be women, people in low income, people with young children. I remember myself trying to do that juggle of working from home with a very young child. It was really, really testing for people, particularly parents and carers of children with disabilities, of all people with disabilities and enduring mental health conditions. Older people, especially living alone, that cocooning message was very hard and had some very negative impacts on older people living on lone parents. In terms of the health system, women who gave birth, parents who gave birth during the pandemic, was a very isolating, difficult experience. And obviously people who died during the pandemic, people who died in nursing homes and in hospitals and their families. And I think it's important just to name those in the context of today. But also those with long COVID, and certainly, and there's people still with long COVID, but the people who bore the brunt of that were the healthcare workers, or the people working in supermarkets or in lower income jobs, who were the people who didn't have the luxury of people like me who could transfer and work from home. So I think what we see is this, when you look at any of this in more detail, is there's no black and white here. It's a nuanced, complex, even a contradictory picture constantly emerges of a health system and public health system that went in fragmented and under-resourced, and yet we responded very well. Myself and lots of colleagues have done good research on how the health system responded to the pandemic, often with these really agile, innovative responses, the likes of Patrick and people on the front line working with travellers in halting sites with migrants, in direct provision hospitals, the responses in prisons. So really innovative responses, really strong community responses, the importance of the post men and women, of the GAA, of the pharmacists delivering medicine to people's homes. And yet, the question that Anthony asks, or even Steve asks, is how much better off are we now? And if you look on paper, we're spending 10 billion more on health in 2026 than we did, say, in 2016. We have 35,000 extra staff in the public health system. And yet, how much more prepared would we be for the next pandemic? Many people, Mary Codd, Evan Perry in particular, have talked about the weak status of sort of public health medicine going into the pandemic. And there have been some wins in that in terms of the long sought recognition of public health doctors as consultants. And yet many of the key components of the Crowe-Howarth report and the Hugh Brady report in terms of the non-medical public health workforce that's really needed to prepare us for a society for the pandemic, but also having that public health leadership at the highest levels, public health on the head of the HSE board, or as part of the HSE board, public health as driving on our reform is still really needed. I think there's some interesting things for us to understand as an evaluation panel in terms of when the public health evidence was used and listened to, so the quick lockdown, us all staying at home, the uptake of vaccinations, but also when it wasn't listened to. Like we were slow on some key measures, masks, the guidance around masks, around home testing, antigen testing, we're very slow. So I think understanding that for future pandemics is really important. And then just a few minor points, Derval, and I'm done, and bringing us back to context. I think, and it was a meeting Professor Anne Scott and myself and others had with HICWA last week of understanding some of the decisions that were made in the context of the health system capacity. So some of the advice that was given, say, around masks for us all to wear cloth masks was because just we didn't have the high-tech masks, or we were keeping them for the healthcare workers. The laboratory, Mary Codd, you just gave this excellent input, really opening up just that the fiasco, maybe how that particular part of it was handled. But part of that was the very low capacity and the running down of laboratories in advance of the response, and areas like that we really need to improve on to be ready for the next response. And I don't think 6 years later we've got there yet. Finally, I think for us to understand that health systems and public health and pandemic preparedness is both complex and human-centered, and if we begin to understand the interrelationship of measures, so we lock down really hard because of our very fragile, underprepared hospital system, and we can't do any of these single measures on their own. They need to be really interrelated, and therefore all the more reason that we need to get those foundations right. The poor IT data infrastructure highlighted by Anthony Staines, still not spending enough on public health and prevention. We were very poor spenders in advance. We went up during COVID. We've retracted back down to that. Not delivering enough of that primary care, prevention, integrated care, but also Mike Ryan's key point about implementing existing reforms. We've yet to reform our mental health system for people with who need mental health supports and enduring mental health problems. We've yet to implement the recommendations of the many reports into nursing homes so that they're fit for purpose for the next pandemic. We're yet to implement key measures of sláinte care, like a universal entitlement, in particularly to primary and community care, and that we really need to get those mainstream sort of health system, public health policy building blocks right in order to be ready for the next pandemic.
Thank you very, very much, Professor Burke. And that concludes our individual contributions from the experts. But we now move on to a group discussion. And just reflecting on this morning, Professor Mary Codd reminded us that it's almost 6 years to the day since COVID arrived on these shores. And And it's really interesting to interrogate our collective memory of the pandemic, because it is that collective memory that we have, and it's entirely understandable perhaps that we don't want to recall it in any particular detail, but that collective memory will shape our preparedness for the next crisis. How we remember the pandemic has the potential to influence decisions on spending, on research, and as we've heard from all of our experts, our response to future health emergencies. Be interesting to see how our public perceptions, our collective memory on the pandemic softened over time. Perhaps we look back and think perhaps it was an overreaction or an over-exaggeration at the time. But Dr. Mike Ryan, I might go to you first of all, just to say, do we need to be reminded? It's perhaps understandable that we don't want to look back at those difficult dark days, but when you think to Bergamo, when you think of field mortuaries and other facilities being prepared potentially as oversupply for morgues, do we need to be reminded of what we were facing at that time in order to prepare for the next one?
Sort of yes and no. Ordinary people need to get on with their lives. They don't need the Cassandras of public health telling them they're all going to die next week. That's not the role of public service. The role of state and public service is to work with communities, to deal with those issues in advance, prepare communities without scaring the living daylights out of them. And so it's easy to be the flag waver and do that. And something must be done club. So I think we need to separate in here people's natural desire to get back to normal life and to get back to getting their hips done and getting back to having their mental health issues dealt with and building a strong health service, a more comprehensive, multi-sectoral, inclusive health service. That is the primary goal. And have the faith that such a multidisciplinary, such a well-distributed, inclusive health service will do better in the next pandemic, no matter what. But a service as well that just doesn't rely on that existing infrastructure for its resilience. It's naturally resilient because it's been built well. But we also have to know how to build a quick extension when the time comes. And that may mean we may have to lay down some foundations for the surge capacity we need. It doesn't mean we have to build all of that, but we have to have the basic infrastructure, but it can't be separated from the system. Building things outside the system is sometimes necessary because it's a crisis, but that in itself is a failure. It's an admission of failure. You're admitting we can't use the current system to do this because it's broken. Then you get on and do it, and it wasn't the wrong thing to do to build a parallel system. You had to. So you don't blame anyone for having to build that system, but you need to go back and say, why did we have to build a parallel system? Why did we have to reinvent IT systems? Why did we have to do all this with labs and animal labs? That's the question. It's not who's to blame for that. And I think that's where, Ireland needs to move forward. I think the idea of a healthcare system, everyone in the world is living with the reality. We have a disease care system, not a healthcare system, and moving towards a more primary care, community care oriented system where the pointy end of the system, the innovation and everything we see in tertiary medicine is fantastic. If I get a brain tumor, I want the best neurosurgeon in the world doing my surgery. We all have that desire. But the reality is the majority of our lives are spent accessing healthcare in a primary healthcare led system. And the system in Ireland, to me, and this is a personal comment, doesn't seem to be yet primary healthcare led. It's tertiary healthcare led. That doesn't mean I disagree with tertiary medicine, but the true commitment to a community participation in a primary healthcare led system means turning our system slightly upside down. It doesn't mean degrading parts of that system, but we've had a system we in Ireland, I think, tend to pay homage to the expert. We want to find the expert of the expert of the expert, and that's the person who gets the attention. And we tend to ignore the public health nurses or the nurses or the frontline GPs. They're just part of the system. And I think we have to turn that around if we're going to be successful in the next pandemic. So I think there's lots of lessons to be learned, but I think the biggest one for me is we need to get the health system right, and then we'll be right in the next pandemic.
Thank you very much, Dr. Ryan. I wanted just to bring you in, Dr. Tegnell, you were, along with Dr. Ryan, one of the people who was out doing those daily briefings. You had a huge role in respect of public messaging and communication. And I was just wondering, when you look back, Anders, is there any evidence or info that you felt had the greatest influence on the pandemic response in terms of the public's understanding of, the approaches that were taken, just to look at that communications role, particularly in light of the fact that misinformation and disinformation certainly accelerated during this period?
Thanks. First of all, I would really like to say, Mike, that I fully agree with you. We need to build systems that are resilient. We cannot have separate systems that take care of the crisis, because that will not be sustainable. But to your question, I think two things were really important to us. One is that we continuously kept on trying, at least, to measure the trust from the public by doing questionnaires every 2-3 weeks. And the feedback we got from those was that people kept on having a very high level of trust in us and how we dealt with the situation. And since many of us said communities are so important for us in dealing with the pandemic, that was really so important to us, that knowing that the community was sort of behind us and the way we were dealing with things. So I think that was incredibly important. The other part is that we tried to, in different way, measure the compliance of the public. We could follow how they changed their behavior through the mobile phone operators. We could, to a certain extent, also follow how much they worked from home. We could follow how many of them went with the subway in Stockholm and so on. So we tried to use different kind of measures like that, and to find out if people really did change their behavior and did meet fewer people. And all the data we got back said that, yes, people do change their behavior to an amazing extent, I would say, afterwards. And we could also see it in that suddenly we didn't have any respiratory infections in our system. There was no flu, there was no RS virus, and so on. So I think all of these indicators that people actually listened and tried to work with us in restricting the spread of the disease was very, very important to us.
Very much, Anders. Mary, Professor Carter, could I just ask you just about when you reflect now, and you shared some of the insights with us, the key lessons for testing and tracing and how it could be approached in the future to minimise, obviously, infection spread, but also whilst minimising those huge population-wide restrictions that we and many other countries deployed?
So I think many of the speakers have talked about preparedness. And I think that while undoubtedly, once we got going, eventually we actually did quite a good job on the testing and tracing, but it took us too long to get there. The decision making was too slow. And we somehow believed maybe we might not need to pay attention to the experience in Wuhan or in Northern Italy. So I think that mindfulness, if I may call it that, of the things that need to be done ahead of time and prepared for, and it very much echoes what Mike was saying. I would say if there's one thing I'd love to do, I'd love to see done, is to document what we actually did do well eventually in terms of testing and tracing. The commissioning of services could have been much faster once the recognition was there that we needed those services, whether it was testing services, IT services, infrastructure. The upskilling of a workforce. We've talked broadly about having a resilience on a stand-up workforce that is trained, perhaps convenes twice a year, is continuously kept abreast of what's happening. They may not be an infectious disease or a public health workforce, but we had fantastic experience with those people becoming upskilled. I would say that NEFIT, where's it gone? We actually need to have an ongoing presence of NEFIT needing to meet, periodically monitoring what's happening in the wider world. And I say that from the perspective of being involved with the network in Europe, which is the Association of Schools of Public Health in the European region. we actually have a weekly meeting that started out as a COVID-19 meeting. Every week we continue this weekly hour-long meeting. We cover things like what's happening in terms of Mpox, avian flu, Marburg virus, measles outbreaks, CDC, ECDC policies. It kind of keeps everybody at a level of, I won't call it preparedness, but knowledge. So I would like to see that this, that the body, which is NEFIT, is resurrected and active. It doesn't even have to meet every week, of course, but that there is some sort of quarterly presence of this body. And that, in turn, will generate the impetus to say, well, what is it that we perhaps need to learn? What is it that we can do to be a bit more ready a bit earlier?
Thank you, Professor Code. I wanted Mark maybe just to speak to you about that, inevitably when we have major public health crises, politicians and policymakers have to consider trade-offs. I suppose decisions have consequences, whatever way you look at it. And it's obviously perhaps a little bit easier now to judge those early, the decisions that were made in the early phase of the pandemic with the clarity of hindsight that we have now. But what do you think, reflecting now, are the best or the optimal means of balancing that protection of the truly medically vulnerable people and the wider population when you look at those health-based consideration and measures that were taken, bearing in mind that each pandemic has its own unique features and challenges, as we've heard?
Yes, and that last point is very important. I think Mike made it first, that we should just prepare for the pandemic we've just had. But in the context of the COVID pandemic, I think the main issue was that we didn't fully focus on who was the most vulnerable group to this pandemic. We went for blanket responses that targeted everybody. As one comment was made at Scottish Advisory Group, that we've effectively asked everyone to act as though they're infected. That's what self-isolation, staying in the lockdown was. That was what you ask people who have tested positive to do. We were all asked to do it. So that immediately tells you there's grounds for better surveillance to understand people's disease status, which incidentally is not a new public health idea. So the control of the HIV/AIDS pandemic was all about know your status and safe sex. That is exactly the equivalent of what we needed for COVID in the context of the transmission of COVID. Know your status and behave safely. That's what we need to do. We didn't do that. We targeted everyone. Now, your question though was why the politicians went that route, I think, wasn't it? And that's because of lack of understanding. And I said earlier that I think they needed the right quick access to the right experts. So may I give you a slightly tangential example? Our advisory group held face-to-face over Zoom, but Zoom meetings with the Scottish Cabinet, with the First Minister and the entire Scottish Cabinet. On one of those, I was asked to brief them about reopening schools. This is in the summer of 2020. They were thinking of reopening schools in August. And I had to communicate to them some understanding of the risks to the children of doing this. So I said, we've done some research on that. It was a difficult thing to estimate precisely because it was so low, but our best guess was the chance of a child going to school in Scotland and dying from COVID that they caught at the school was roughly equivalent to that child being struck by lightning in the playground. And what was so striking, because it was Zoom, you could see, this is the cabinet, you could see their faces, just the jaws dropped. This was simply not their understanding of the risks. And from that exact moment, it was clear they were going to have no choice but to reopen the schools. So they've got to have access to accurate information. They clearly didn't have it, all the way up to the summer 2020 on what the risk to children was. And I think that's the way you get appropriately targeted interventions supported by the politicians.
Professor Heyman, you are shaking your head. I think in agreement. What's your observations on that, just in terms of that difficult risk assessment, especially as we've heard from many of the contributors, when the information itself is uncertain, particularly at the outset, that can challenge evidence-based advice that is given?
Yeah, I think you could nail down the problems to the fact that evidence was not used as it should be used. And so the initial response was very difficult to modify, even when evidence came in that you could modify it, as Mark has just said. And I think that takes us back to what the role of the government really is and what the role of others are. And I think governments need to understand that they must facilitate what communities do, because communities are where you can detect disease, where you can respond rapidly with trust among the people in the community level. And as Mike said, you need to really turn things upside down and begin to consider the communities as the pillar and then the government as the facilitator.
Thank you very much. I wonder, thank you for staying with us, Professor Staines and Dr. Tengel. Professor Staines, I just wanted to bring you back to that whole question of how do we build crisis-ready health system resilience. It's something that you spoke about in terms of, balancing sustained increased capacity versus the ability, as Professor or Dr. Ryan mentioned, to achieve surge capacity when we do have a crisis.
I think it's a challenging problem. I think the process that Mary has outlined, where we have a substantial cadre of people who have a level of training which is kept up to date. So you end up with something a bit like basic life support. Most people who are trained in basic life support never use it. But the idea is that if you collapse near someone who's trained in basic life support, that their training will kick in. That's what you hope. I think something similar to that is where we need to go with this. And we do need to bring the communities with us. We need to be willing to explain to people that at the start we don't know. So, for example, I remember at the very start of all this, we didn't know much about who was infected. We knew it was spread by the respiratory virus. But we also knew that children got devastating illness from it. What we didn't realize was that illness is extremely rare in proportion to the number of infections. We didn't know that then. We know that now. We've known it for a long time. But that explains some of the fear around children. If we look at masking, you're quite right. WHO originally recommended that surgical masks be reserved for healthcare workers because there weren't enough. And in due course, that N95s be reserved for healthcare workers because there weren't enough. And then they became widely available. So the advice on how one should go about masking changed over time. And it is striking that the Department of Health continued to use the words face covering and avoid the words masking right up until the Christmas outbreak of COVID. So I think we have to be very serious with the population that there are lots of health problems, most of which they deal with. We have a health service which is built, as Mike has said, I think, around tertiary care. It is not fit for purpose, has not been fit for purpose for quite some time. We need to build a health service based around self-care. Because if you do the figures, the vast majority of healthcare is self-care, based around led by primary care. And we don't do that. We still have a very splintered community care workforce. Primary care and community care talk to each other on the basis of strong individual relationships, but there's no structural piece there. And we need to get all of that right. We need to be clear with people that we will always tell them the truth as far as we know it, so they continue to trust us. Because trust, as is often said, takes years to build, but only minutes to lose. And it is
Absolutely.
clear that we have lost the trust of some people.
Thank you, Professor Staines. I wonder if I might move to Dr. O'Donnell and Professor Leahy-Warren just on, because you both spoke to the disruptions of non-pandemic healthcare and service delivery during the crisis. And I'm just wondering, Professor Leahy-Warren, have the opportunity costs or those longer term impacts been fully understood or realised in your view?
No, I don't think so. And I think that is the word on the ground also, that we are 5 or 6 years later into this. And now we are seeing children in particular who are not school ready. There's a lot of anxiety, whether it's they were born during the pandemic, they had little socialization, their growth and development has been delayed. They've missed opportunities when they didn't meet milestones, but they weren't in any position to be able to be assessed by the public health nurse because they weren't in position to do that. So we've lost windows of opportunity for growth and development. So I suppose this comes back to, I think we do need to look at, I think Professor Ryan just said it there, we need to build a system for the next pandemic within the current system. So it's like implementing any science. You need to build it into the current system, not as a separate, because then it becomes outside it. So we need a minimum level of preventative services at the next pandemic, so that we're not going to be in the same position again. And I do appreciate everybody here is saying we don't know and we didn't know. But as the information came on and the evidence became on board, we needed to act on the evidence very early on, knowing that school children, knowing that smaller children, knowing that this could have been done earlier. So we missed very subtle, experiences which could have prevented longer term impacts. So this is ongoing for us in the public health nursing services.
It's something that you spoke to as well, Dr. O'Donnell. We've heard today about the burden of recovery and the burden of deferred care, and alongside the phenomenal response of frontline workers, the burden and impact on those. And I think as Steve mentioned, that it's the legacy of this crisis that will determine the starting point of the next. So do you feel that those long-term impacts have been fully captured or crystallised yet?
On patients or on staff?
On patients and staff.
On patients. I suppose there is work ongoing in terms of things like cancer diagnosis, screening, cervical check, and some of the other, I suppose, conditions. And it will take years for some of that to filter through, both of the kind of primary care detection and also in the secondary care results of that. Staffing wise, I suppose it comes back to what's been suggested already in terms of it's very hard to be adaptable and when you're at max capacity to begin with. So in order to be able to innovate or to react or to bolt on those extra services or extra, you need to be working below capacity to begin with. So it comes back to the comprehensive, well-resourced, equitable health service in the beginning in order to be able to kind of deal with that. And the staff that are working in that system, I suppose, are owed that. There's an understanding a little bit more of it after this pandemic. Yeah, and I was just thinking as well, like between public health nursing, GPs, primary care teams, they are experts in context. They know the communities that they work with. They know they're very good at reconciling with communities around what would be needed in terms of adapting and trying to move things forward in a shared way. Yeah.
Just might bring you in there. I want to speak to perhaps Professor Perry and Dr. Nat O'Connor just about maybe that from a economic or a broader context. But before that, Professor Thomas, you identified two key legacy issues, including waiting lists that you say could determine our preparedness for the next pandemic. So do you think that those impacts have been fully understood or crystallised as yet?
I think in terms of the waiting lists and the impact on demand, I mean, we're seeing that played out in real time. And I think one of the things that I have to give credit to DEPA for is rather than taking money out of the health system after COVID, it's actually kept money in the system for dealing with things like exactly these things about the extra care required. I think the problem then comes though you're sort of tempted to put extra pressure on the workforce coming out of COVID to actually deal with all those new problems or the old problems that we didn't deal with during the crisis. So I think that there has to be extreme care taken with how we manage that, how we provide care. And I think the system it really knows it needs to move much more towards integrated care, to developing primary and community care. And I think that would take some of the pressure off the hospital. So I think advancing the reform program would both protect the workforce and protect and deal with some of the waiting list of problems.
Can I just bring you in, Professor Burke, just on, we've heard a lot today about decision-making structures and governance. And I'm just wondering, how do you think that impacted the overall level of the coherence and the competencies, I suppose, of decisions and approaches that were taken in your view? In your considered view?
The easy question. I might defer to Professor Scott on that one. I think, to the best of my knowledge right now, we didn't do what was the official plan, right? So there might have been a pandemic plan that we didn't implement, and then there were these official government structures as a response, and we didn't do either of them, and we went with the NEFIT public health advice to this caretaker government. So we didn't play by the rules or the rules that what we were meant to do. And therefore, I think we can definitely do much better next time in terms of having adequate government structures. Like, there is an emergency government response that we didn't actually use. And also having a system that's much more prepared for that next crisis, whether it's climate related or a pandemic. That said, even though we didn't do those things, we did quite well. And also, two very brief points I'd love to come back to, Derval. One is in terms of communications and just the picture that was painted internationally. I think we actually did quite well on communications here. I think those daily briefings by the CMO and the deputy CMO lineup of HSE staff, they stayed until the last journalist answered a question, and hundreds of thousands of people watched them. I know they also had negative health impacts upon people, but I think there was a high level. Everybody became armchair epidemiologists doing things. So I think that level of communication is a positive thing, and the public are well able to take on complex information and deal with it. And then the second point is just in relation to that redeployment of staff, that all these key cadres of staff, like public health nurses, like dentists, therapies, were redeployed onto the COVID response, and therefore we're still paying the impact. And we really need a better plan next time around this sort of reserve workforce of students or retirees or people in the system who are willing to go, and we didn't have that ready to go. We did a good makeshift, as is the example of COVID tracing, but we weren't prepared for that. And therefore I think that governance needs to come from the bottom up, from the communities being ready, the health system being ready, but also a stronger government readiness for it.
Thank you very much, Professor Burke. Professor Perry, I just wanted to bring you back into the conversation because you were able to broaden our scope and let us look at broader kind of socioeconomic and cultural issues. In your view, what were our strengths and weaknesses?
When we entered the pandemic hugely advantaged in many respects. And I suppose our strengths, as Steve has pointed out, the health system, the acute health system, did respond with great creativity and effectiveness in those early weeks and months. Whereas I think our major weakness, and this brings us back to the point that's been made by multiple speakers, that they they need to generate and respond to evidence at local level in real time, and that's where our deficits in public health medicine and infectious disease epi really let us down. And just to take one example, we had a protracted debate, it seems like for almost a year, perhaps it wasn't quite a year, about lateral flow testing, whether we should introduce it. And there was huge concern about false negative results. But I mean, what we needed were studies, local studies, to test that hypothesis, just to see. And obviously, there was some international data that we could have drawn on there, but it really would have been helpful to have local data to inform us on issues like that, or indeed to get real-time data about the actual risk of outbreaks in schools, for instance, that would have helped our decision making. So I suppose I come back to the main point that I tried to make, that there are many things we need to do to prepare for the next pandemic, but one of them has to be to further invest in our public health medicine capacity department, because of course public health medicine has many other roles apart from health protection. I think that has to be a key.
And that was
learning.
really very foremost in Patricia Lee Warren's contribution, just the broad work of the range of our public health nurses and those frontline officials. Dr. Nat O'Connor is a member of the COVID-19 evaluation panel, and I was just wanted, maybe having listened to all of our individual experts, in your view, what lessons are there for future similar crises?
Well, I think I could say a great deal of things, but I'll try and limit it to just three observations. First of all, I think it's very clear that we can't talk about our health system separate from our economy or our wider society. We know that health measures such as the lockdowns had an enormous effect across society and the economy and so on. And we also know, of course, that the structure of our economy, the nature of our economy, inequalities in our society, all are determinants of health outcomes, and that we can't think about achieving a healthy society unless we also look at those things. So I think bringing those things together, we've seen the example of Scotland where a social policy advisor is now part of decision making. I think that we need more of those kind of interactions. We need human rights inputs and so on into this decision making. So it's not purely health focused, but it's seeing the wider social and economic picture. So I think that's very important. I'd have two other areas which I think we need to look at in some detail. Mike Ryan and others mentioned we've had countless reports internationally and here in Ireland for all sorts of different types of health reforms, and recommendations remain in those reports on shelves, and we're not seeing the implementation. And so that question of how do we translate what we have learned into action? And I think it's not a case of simply raising our voices and saying, well, we should insist that the government take on these recommendations. We need to look at those jurisdictions, such as Korea, which invested $250 million in their public health systems. What is different about their government systems, about their society, about their attitudes towards healthcare, that they were willing to make that investment? So we need to look at the determinants of investment in those countries that have learned lessons and have implemented them, because it's quite clearly the case 6 years on that in Ireland we have not implemented, and indeed there's a succession of reports that we have not implemented recommendations from. So we really need to look at those countries where they take these things more seriously and where there's a political appetite and a social appetite to put in the investment needed to make those kind of structural changes, because they're not free. And the third thing I'd ask, which is, I think, given the expertise sitting around the table, I think we should perhaps, if it's possible for someone to comment on what is the risk of COVID today, because some people who are immunocompromised are still worried. Some older people have not returned to using public transport. They still wear masks. They're concerned. Long COVID is a concern for many people. What is the level of risk of COVID today? I think that's something we also need to look at, and I'd be welcome anybody's comment on that.
It brings us back, Dr. Connor, I suppose, to Dr. Ryan, your opening remarks about how context is key, and it's not just geographical, it's cultural, it's environmental and social. So to wrap up our group discussion, I'm going to perhaps ask you one final question. You might want to pick up on Nat's very salient one, but what should a future pandemic plan for Ireland look like? An easy question for the final one.
I'm the wrong person to ask, because it's very easy to really on the sidelines. You know, I spent enough time on GAA pitches, but shouted at by people who weren't playing the game, right? So I think that's one of the things we need to avoid, is the pontification syndrome of me telling you what to do, because I have no accountability for the outcome. So
what would you like to see then?
Well, I think what Sarah Burke said, I think overall, given all the starting points, it was really interesting for me coming home to hear, the honesty and the way people, looking at the realities that existed in the system. The Irish healthcare system There's a very strong, generally equitable system where people work really hard to try and deliver solutions for people's health care. And people worked really hard during the pandemic. And the perception abroad was a very trusting community that were willing to implement, health workers working hard. Everyone tried to do their best. And therefore it's very important that that's recognized. The community did a great job. The health system, the people in the health system did a great job in the circumstances that everyone faced. So people should give themselves a small pat on the back, but then recognize the damages that were done in certain sectors, be it long-term care or the impact of the lockdowns on the child health care. There's one thing I keep reminding people, because I challenge people on this. At no point did the World Health Organization ever advise lockdowns. We consistently advise balanced public health measures based on the risks, because we had to manage the issue of the risk in a country. You could advise masks for everyone, but if you're living in a developing country, that wasn't possible. Or lateral flow tests for everyone, that wasn't possible. Okay, they're only $1. Well, $1 is a lot of money in an economy where people make $1 a day. Or maybe make $1 a day and barely get food on the table for their families. So it's all very contextual. It's very easy to say this is what you should do or that. What I think Ireland needs is a dynamic, adaptable, flexible and agile health system that's able to react to whatever the crisis is. And down the line, we may be dealing with weather events, heat waves, we hope, maybe, but other events that will come down the line. Climate change and everything else are driving it. So we need a multi-disaster or a multi-emergency type system that's in place that's able to surge and adapt as needed. Ireland is well on the way to doing that. If the smart people get in the room with community leaders, I think that can be delivered. But it's for me, it's Ireland should, in general, while looking at all the issues, I'm sure, Anne, you've been looking at all the holes in the system. The external perception of Ireland's response is one of people who work really hard at every level to try and take care of other people. And I think in general, that's positive for our society, notwithstanding some of the harm that was done, maybe well-intentioned.
Yes, thank you. Professor Leorn.
I just want to give, I suppose, an anecdote come to what you're saying there in terms of disasters or weather warnings, or now that we all have names for these storms. My public health nursing colleagues were telling me recently that the local floods, they were called out. So they had a number of isolated residents who really needed healthcare. So it was, again, the community came on board to look for who has the RNLI boats, who needed the generators that they were sharing between different areas. So again, they felt it was a little bit PTSD coming back to the COVID again for the 3 days that it was going on. But again, the COVID pandemic had prepared them even to come together to look at this and how are we going to actually reach these people and how can they be reached in terms of making sure that their healthcare is, addressed in a manner that isn't going to leave them with any long-term effects. So I think, yeah.
Thank you, Professor Leorn, for sharing that with us. Well, one person who's been working very hard beside me, taking copious notes, I don't know, Professor Anne Scott, who's the chair of the COVID-19 evaluation panel, which has been tasked by the government to assess Ireland's pandemic response. I know you probably won't be able to capture all of this morning's discussion, but I'll hand the floor over to you just to share some of your own reflections.
Thanks very much, Derval, and I think Sarah has the right idea. Forget the notes. First of all, I would really like, on behalf of the panel, to thank our participants really sincerely, both online and in the room with us here. I think we've had a very wide-ranging discussion. I think it's well nigh impossible to capture that, but the panel have the benefit of a recording to go back and listen to, and I'm sure we will do that many times. So we really do very much appreciate your time and your expertise and the discussion we've had. I think looking at some of the overarching comments, I think the issue of the importance of context, I think Anders brought that in right at the beginning and has been reiterated through a number of the speakers. And I think this is something which is important in all sorts of ways. Anders, in terms of the Swedish experience, talked about the kind of, I suppose, what you could loosely call a much more decentralized, not quite federalist, but a decentralized system where there was already very high trust among the public in government and in public health. Mike talked about the context internationally and the impact that has. I think, David, when you started and talked about the two words that come to mind immediately when you think about the pandemic in terms of confusion and blame, I think context also has an impact there. You also mentioned Asia in terms of, various countries take various approaches, but there was a kind of consistent approach in Asia. And I suppose one of the questions that automatically generates is why. We know at the beginning of the pandemic, there was a great deal of uncertainty. We know that those of us who had pandemic plans in place at all, it was an influenza-based plan. I think very quickly we learned that COVID virus was certainly different to influenza. However, Asia was building on an experience. And I think this is a really important thing, that we do look internationally. Ireland is normally reasonably good at this, but that we must continue to look out internationally and assess very rapidly why people are maybe taking different approaches. And we knew fairly quickly that coronavirus wasn't influenza, so we perhaps should have looked a lot more carefully at some of our Asian neighbours. I think the issue and confusion and blame continued certainly for the first month or 6 weeks. There was a great deal of uncertainty all around the world, including in Ireland. And there was also a great deal of fear. And I think we need to remember how frightened people were, both ordinary members of the public who didn't attend A&E, who didn't attend hospitals, but also members of frontline staff who were trying to deliver a service in as humane a way possible in a context which was becoming increasingly difficult because of the need to use PPE, etc. And as I think one of the important things for me in terms of your input, apart from flagging the importance of context, was also the impact of what I think you described as being hit very hard, very quickly. And so a lot of your normal responses were overrun before they could really be instituted. That seemed to generate a much more considered, targeted approach in terms of looking at your data, looking at your modelling, and maybe moving much more quickly than many of the rest of us to identify the vulnerable groups and where resources may need to be focused. Now, of course, mistakes were also made. You didn't get it entirely correct in Sweden either, but nonetheless, your society had quite a different experience. As a member of the general public, as a member of the, using ordinary social and entertainment areas, and also including schools, which I think I'll come back to later, because I think the impact on schools has been very significant for us. We're continuing to live with the consequences of that. And unlike Sweden, we had probably one of the longest school closures in Europe. Not the longest, but certainly one of them, etc. I think in terms of Mark's, a couple of inputs that I think will really stay with me is your comment about coming in early can result in a less drastic set of restrictions or set of requirements. And I think also in things you've written, you've also talked about the need to reassess where we are as we travel forward. I think this issue of coming in early and making decisions is very important, because as a number of people have mentioned, if you're sitting on NEFIT, or if you're sitting in the HSE, or if you're sitting in a clinic, you don't have time to read 7 articles and then have a discussion and then make a decision. You actually have to make decisions. The issue is we also then need to take time perhaps to reassess as we go down and the evidence changes. I think a second thing from your input that will stay with me is the need to take seriously the role of the public. We're used to things, and Anthony, you did mention it, we're used to sayings like nothing about me without me, but actually we no longer hear it. It's kind of a bit of background noise largely. However, I think this issue of looking very carefully and thinking carefully about how a society needs to operate automatically says you have to involve them. In hindsight, that seems obvious. It wasn't necessarily obvious at the time, and we do know that as effective as NEFIT may have been in certain areas, it was very much public health focused from the beginning and stayed that way largely, even with the 50 odd around the table. It was still very much a medically focused and public health led discussion. That worked in certain areas. It made us, I think, in Ireland, very slow to recognise the downstream impacts of many of the restrictions. It made us very slow to recognise the psychological burden on people in terms of mental health issues, in terms of disruption of our normal waking, funeral and burial issues, in terms of the impacts on school closures and in terms of the impacts of isolation. So I think this issue of actually taking seriously the role of the public and thinking about how that can be leveraged and used creatively next time around, I think would certainly strengthen our response. I think Mary and Ivan, you very quickly took us through not only where we started in terms of the infrastructure and the sense of demoralization in public health, but also some of the key issues that emerged. And I think particularly in terms of the contacts tracing centre in UCD, I think there is a lot of learning from that. And I think certainly some of the early indications that were coming from that could have short-circuited the length of time it took us to start looking seriously at our long-term residential care. And the consequences of that has been really devastating. I think in terms of Anthony's comments, I particularly was struck about your very clear statement in terms of the lack of preparedness and that we were really not in a great deal better position than we were 6 years ago, but also some of the comments you made about NPHET, because I think, as Sarah has pointed out, NPHET possibly benefited, for want of a better word, from the fact that there was a caretaker government in place who actually did have a medic at the head of it, and therefore got very quickly the fact that this was a public health crisis. And I think our CMO also got very quickly the extent that that crisis might evolve into. However, it is very public health focused. And as has already been pointed out, a lot of our normal emergency decision-making structures were sidestepped and not reintroduced even later. And I think that also has had very significant consequences on some of the decision-making as it evolved through the period of the pandemic. I think, Mike, you made a couple of, you always make very pertinent, well-made comments, but I think that a couple of them were very important from my perspective. And one of them is this notion of blind spots, and we all had them. For me, the importance of that fact is we're likely to have them the next time too. It's part of human nature. Many of us actually had the same kind of blind spots internationally, long-term residential care being one of them, for example. Our willingness to, as soon as we discovered we maybe could impose lockdown, to do it without thinking about what the alternatives were. But I think it's the fact that we will have blind spots may make us more vigilant next time around. And it certainly should make us more vigilant next time around. I think also and this is a quote I've heard from you before, this notion of rapid action means very likely it will be imperfect. And I think that's also a very important lesson for us. And I think it goes back to David's point at the beginning about blame. If we blame people for making the wrong decision in crisis when they're trying to do their best, we will end up not having anyone to make decisions or to look after us when we need them. And I don't think any of us want to be in that situation. So we want to recognize the pressure, the extraordinary pressure that decision makers were working under and that many staff were working under. And we want also to accept, as a normal part of decent human activity, that most of us are trying to do a good job most of our time. And we'll all have off days, but in general, we're trying to do a good job most of our time. So we need to give each other the benefit of the doubt. And I think, as Martin Cormacan, one of our infectious control people, would say, we need to be a bit kinder where we have the option to be kind or be otherwise. We need to be a bit kinder. We also need to recognize we did make mistakes. We did get things wrong, and we certainly need to learn. But we can do that without castigating or causing major trauma to the individuals who are in the front line trying to make those decisions at a point in time. Steve, I really enjoyed elements of your presentation, and I think the bit of it that I probably took most from was this notion of you focused on two areas. One was the waiting list issue, which unfortunately is such a long life issue in this country that maybe the seriousness of the impact of COVID on it hasn't quite completely filtered through to us as those of us who are not in the immediate care scene. But I think your comments in terms of dealing with that as a matter of urgency and dealing with it in a way that becomes sustainable is very important. I think the other issue is about recognizing the need to care for and protect our staff. I think we are, as a nation who would normally have a reputation for a reasonable degree of humanness and engagement, I think we are singularly poor at really looking after staff. And it's not only in the health service, it's right across the system. The first people that we will need are those first line people. And therefore, if they have an experience where they're constantly exposed, not protected, and then not looked after when they do become ill, I would say as a society, we are in serious trouble. Patricia, I think again, really interesting to hear, I think the experience that I had picked up anecdotally in terms of the disruption of public health service, particularly public health nursing services on the ground, and the legacy that we are currently imposing on a couple of generations to come. And I think that's